Let's discuss about a far lateral approach or para UBE in this case of a disc recurrent herniation of the L45 level. You can see the facetal artery, which is very important to coagulate. In the beginning phases of surgery, you can very well see the joint capsule. So you have to understand the SAP and IAP are located in posterior and anterior manner. So first you work on the SAP, IAP, then you move to the SAP. SAP is seated deeper, so the capsule, joint capsule, will guide you most of the times for the limits of the joint. Now drilling with a diamond drill is very handy in these cases to make the space and increase the widen this foramen. So the 9 o'clock position, you can see the foramen. I'm trying to drill, I'm trying to negotiate to the foramen. So that first thing is I should identify the exiting route. So you have to understand para UB or transforaminal UB is outside in technique. So I'm hitching on the pars area. You can very well see the joint gap. This is the SAP, tip of the SAP. You need to drill the tip of the SAP to widen the area. In this cases, so the tip of the SAP and the joint capsule and the gap between the two joints are very well visualized. This is the foraminal ligament. You are seeing the yellowish part of the ligament which is covering the exiting route. So now I'm working on the tip of the SAP, which points towards the direction of the exiting route. Small carisons are very handy in the initial trimming of the foramen. So I'm trying to tease out the foraminal ligament from here. You can see this area where the foraminal ligament having its attachment. Then you will use a curette to gently push the ligament out so that underneath you can see the perineural fat, so which will point towards the identification of the exiting route. So you can very well see the perineural fat here, the cushion which provides cushioning to the root. Now we try to define the root. You can see the glimpse of the root. So root is to be the identified. Root has a vascular supply on it, so through which you can identify the root and differentiate it from a disc. Disc will be having annulus fibers, where root it is absent. So you can see the root. You have to define it a little more. So how beautifully the root is coming out in the picture, you can see. Now you have to identify the place between the tip of the SAP and the root, which is your Cambin's triangle. So very gently you tease off the area and make a space for the discectomy. This is a redo case which was operated elsewhere by another endoscopic technique. So doing a revision, so I preferred this route to remove the disc. So I am a big fan of the curette in phases because it protects a lot of neural structures. Once you identify, I am using my sheath holder, sheath retractor, advanced it so that it can retract the root. And this is the area where we're going to remove the disc. RFs are very handy to make the annulotomy as well as annuloplasty, both. Now the discectomy is carried out. This is a outside in technique, so provides a very wonderful visualization of this area. You can see many structures. So the pathologies like far lateral disc, recurrent disc, annuloplasty, foraminoplasty, all these are can be nicely done with by this. Unilateral pathologies especially can be handled by this technique. So I'm removing the disc. So some part of the epidural fat is also poking out. So I'm trying to shrink, simultaneously trying to remove the disc from the through the foramen. So see, now the root is decompressed well. The blood vessels are trying to flow through it, which is an indirect evidence of good decompression of the exiting root. So now this is the annulus border, the posterior annulus border which is visualized, and the disc has been removed. So I'll try to do annuloplasty at the end of the procedure, so that I'll be able to do some additional shrinkage of the tissues. Thank you so much.